Perfect. Welcome, everybody, once again to this webinar on perspectives on stimulant use in Europe. Um, we will be having three speakers today. We will have Estera, us, from Lithuania, Karim, Touzani, from France, and Arild Knutsen from Norway. And this webinar is a part of European network of people who use drugs series together with ViiV. So stimulants. This started actually earlier this year because I took on the task of actually writing a stimulant harm reduction resource. And I thought that this would be pretty simple and straightforward until I realized the amount of stimulants there actually are on the market, and the scope of harm reduction one has within each type of these stimulants, and it is very, very big. It's a lot. So basically, I've put my own vision for this stimulant resource a little bit down to collecting case studies from Europe of people who work with stimulants and showcasing these. We will, in this webinar, stick to the main stimulants in Europe, which are amphetamine, methamphetamine, cocaine, and cathinones, not to forget. Um, and the other ones we will leave out of this webinar, but they will be included in the resource itself. So what do the figures tell us about stimulant use in Europe? Well, it's quite interesting. I'd say the cocaine prevalence, it seems to be on the rise, and this seems to be uh, a general trend in Europe. Um, some countries even it's different, of course, from country to country, but some people even call it a cocaine tsunami. So it's here and it's coming. And if you look on the right side figure, there are very few blue dots which indicate a decrease in use, and there's quite a lot of orange um, dots which indicate an increase of use, which is says something. And I think uh, this figure here, I mean, cocaine is after cannabis, so the second most commonly used illicit drug in Europe. And I look at this figure down here, and we see that the seizures are going up in amount of tons, and the purity at the same time is also slightly going up, and the price is slightly being reduced. So I think that this picture, which is actually just copied and pasted from the European report, it should make decision makers ask themselves some questions about how their policies are built. Amphetamines, um, also the same thing. We see that the amphetamine itself is yeah, Nordic love amphetamines, it looks like, and a little bit further south, but down in the south, it's not so much. And the same thing, uh, and then we have the methamphetamine, which seems to be more, you know, at home in Eastern Europe. So it's yeah, it's trends and it's, but of course, as we can see, they are all available everywhere. And then the synthetic cathinones, and this is where I found there was no beautiful little maps, interactive map that we could click on for the cathinones, unfortunately. But I'm thinking that this will be a thing in the future, definitely. I'm sure that EUADA will provide these. Anyways, there's so many. I mean, we've all maybe heard about the 2 mmC, 3 mmC, 4 mmC varies, but there are so many more. And without having put myself into it, I'll take the EUDA word for it, that 178 different types have been identified, which is a lot. And I suppose I think Estera will probably talk a bit more about this, but I suppose not all of these cathinones are the same to each other either. So and needs a different approaches. So this is all. Anyways, harm reduction of stimulants. Let's put it this way: it has involved. I mean, we have had a wonderful increase of harm reduction the past 3 decades, but somehow, uh, they have failed to really address the stimulants issue so far. There are some highlights. We have the UN last year, which is actually put through a resolution which has not been discussed much by anybody actually, but it was about promoting research into the available of scientific and evidence-based interventions for treatment. Okay, so that's a very broad uh, naming, of course, but maybe it can open up for some substitution medication. I don't know, maybe, but I hope so. I think Arild will talk about this a little bit later. Um, so also there is some progress. The UNODC have also, produced a lot of stimulant resources, which is good because basically it opens up that they are actively working on it in any case. There are other new resources being developed by coax, and I mean, if you look for stimulant resources on the net, you will find very many. And in our resource, we will try to list trusted resources for stimulants in our resource so that people will know which ones, are serious and can be listened to. So, January, we're hoping to present a short version of the your input stimulants resource, but I'm hoping that it will be a online. It will continue to be an online resource where it grows. When things change, it changes. When people want to add things, this is also possible. So it won't be just a tiny little resource. Hopefully, it will grow out to be a resource which can be used by us all. And these we'll now hear from our three speakers presenting three different perspectives, different perspectives on stimulant use and how we meet it. These perspectives especially capture experience from intersectional uh, sites, including women, gender diverse people, people of color, and migrants. So it's very broad. So, Karim, if you would like to start, I don't know if you have can change yourself, but if you say next slide, please, then I will change the slide for you.
Okay. So thank you very much. Next slide. I'm Karim. I'm part of Galette. Galette is a broad. You can. Okay. Okay. Next slide. Next slide. Okay. Galette is a grassroots association of smokers of crack cocaine and stimulant cocaine. We are a young group. We have 1 year old. So creation. We are based in Mantes-la-Jolie. Mantes-la-Jolie is a little town, just with a population of 14,000 people. So, and we are 31 people in Mantes-la-Galette. But in France, we are 68 million people, and 35 million people are adults. So in France, when you tell there are a tsunami of stimulants, 10% of people 10% of adults in France tried once cocaine. 3%, 1 million people use cocaine once in a year or all days, every day. Okay, so cocaine now in France, people who sell cannabis sell now cocaine too. The, everywhere you can find cocaine. Okay, we have a few people who use MDMA, and now we have 3-MMC and catenan. We can find. Sorry for me. In France, methamphetamine is very rare. It's yes, you don't have just in South France sometimes, but it's not a phenomenon, not a trend. No. Next slide, please. Okay. For supplies for harm reduction services, we can find needles, syringes. We can find different pipes for smoking in periods. We can find supplies for snorting. We have drug checking. It's not a problem. We have many. We have too much material, too much supplies, too much different supplies. But we have supplies for. It's not a problem for stimulant use. Sorry, I'm sick. Okay. Okay. Next. Okay. Now, in France, yes, we have a purity of cocaine. We increase. Now it's not possible to find cocaine. But when we check cocaine, it's always between 90% and 100%. The price 50 or 60 euro. So cocaine is really cheap and really good quality. People who use cocaine is 30, 40 years old. They are younger, but the population who adults use cocaine in France essentially. So for young people and for older people, catenan are really used because they can detect use with drug testing on the road. When you drive in France, there are many controls, and many people lose their driving license because they use drug. Catenan, we don't have the figures. We don't know how many people use catenan, but it's increased. This threat increased too, and catenan are consumed by sexer people in free-party scene, younger people, and many platforms, telephonic platform, prophone, 3-MMC. They say that that's 3-MMCs. My next slide. Okay. We have drug checking, and since many years we have an attention about 3-MMC and catenan, and you can see on the board. Before, when you sell catenan, when you sell 3-MMC, it was 3-MMC. After, it was 2-MMC. Now, the half 3-MMC is net, and it is testosterone. This is more stronger, quite more stronger, and people don't know what they use, don't know what they consume. Next. many cocaine user in France, I say, and the reaction is increase repression, increase the amount of fines for drug consumption. Yeah, it's new. Uh, many programs to attack the poor, and now it's new program to attack upper classes who consume who use cocaine. That's the only solution. This solution is doesn't have no future, but they continue to increase war on drugs, to increase war on us. The next, just one solution. We are many people who use drugs in France and in Europe, Europe, but we are many people who use drugs, and we must to continue to organize. There are many groups in France of drug users. We need to work together. We need to think together strategy to fight repression, prohibition. We need we have to we must to be present wherever we are being discussed. When in medical committee and in committee for law, etc., we need to be here. Sorry for my English, I tried. Okay.
Thank you very much, Karim. That was a very powerful and a very clear presentation from your side. It is definitely, we're all working against prohibition here, and it's just so central. And while we say the prohibition problems, they are repressing even more constantly. So this is what we have to fight against, which thank you very much. So now we have Estera from Lithuania, from Young Wave in Lithuania. Estera, please.
Hi. So, oh, sorry. Okay, there we go. I'm Estera. I'm from Young Wave, which is a Lithuanian grassroots, peer-led, non-governmental organization that provides harm reduction services in Lithuania, primarily focusing on young people and recreational substance users. So the specific perspective comes from primarily this side of our work. The situation in Lithuania with stimulants has been dramatically changing over the past few years. Stimulants as a category of substances has always been one of the most used, just like Karim mentioned in France. So likewise, it is in Lithuania. However, the specifics of this have been changing significantly over the past few years. This shift in the landscape of stimulants, I would say it's not by accident that it coincides with changes in government that took place in 2017, a time in which a new party came into power and recriminalized the possession of small quantities of all substances, which has, as a result, increased the number of arrests and incarcerations of substance users of all kinds. And as a result of this, there have been shifts in the way that, in the kind of substances that are most present, and in ways that people try to circumvent these much greater restrictions that now exist. With that, there's been a significant increase in the prevalence of cathinones, which overall are a new, well, relatively new type of, well, group of substances. And as John was mentioned previously, there's a whole lot of different types of them. Your number was 178. I've seen numbers going up to 209 different like analogs and versions and modified substituted molecules that exist, which poses a pretty big problem when it comes to, on one hand, keeping up with this from our side, or from the side of those that want to properly inform and help people that might be using these different things. It also complicates the situation for users themselves. A lot of the time, also, as was already brought up, people don't know what they're getting, and especially because this increase in the use of cathinones is like mostly observed among younger people. That adds a whole other layer of inexperience, and perhaps a lack of information and awareness of how to navigate all of these things. So in preparation for this webinar, I was looking into the different kinds of data that are available on well, different for instance, the prevalence of different substances, the changes in trends, and what I could find to back up the things that I've observed and that we've observed as an organization while working at events and doing drug checking, because obviously what we might encounter at events and from people that we talk to is one thing, but obviously there's always this want of actually having some numbers behind it to make sure that our experience is not anecdotal and actually represents the reality of things. And two things in this case, two things I noticed, many more things as well, but specifically, on one hand, a lot of what we observe in this volunteering work does reflect the numbers that are seen through things like wastewater analysis and syringe residue analysis, and surveys that are done by the government-run broader scope surveys of people. However, there is a huge issue of insufficient monitoring, because a lot of the data that I could find, a lot of it was limited to being before 2021, 2022, which is not a lot of time when you, in certain contexts. However, when there are such rapidly changing trends and just overall things that are changing from year to year or half year to half year, then this data is no longer sufficient, especially in the case of cathinones that have seen this massive spike in prevalence in the past, let's say, 4 years, more or less. Then already data from 2021 does not accurately reflect just how much more that has become, just how much more types of cathinones have become available, how much more people use it, and how many issues also come with it. There are other things that we've also observed from, again, working at events and being involved in the community and speaking to different people in different environments. One of them is, especially among very young people, teenagers and preteens, people dissolving different substances into vape liquids, and this might be cathinones or synthetic cannabinoids, or a whole range of different things, which opens up both a problematic new route of administration, problematic because it's not detectable with reagent testing, since the other components of the vape liquid interact with the ability well, for the reagents to react with the actual substance. Also, it's being used among young people, again, who might be not properly informed and without tolerances to things, depending on the actual vaporizer that is used to ingest it. Different temperatures might promote different amounts of substance that is ingested, and so on. And there have been one-off cases of deaths that occur from this, or hospitalizations. When this happens among very young people, the media takes these stories and runs very far with them, which further limits the kind of programs, the kind of help that can be actually organized and done for the people that need it. A lot of it turns into fear-based misinformation, and that in itself, in a system that's already heavily stigmatizing of all kinds of users, and which lacks a lot of the support from both the government and any kind of or government-funded systems, or in general, we're in a place where there is no that there are no specifically tailored treatment options for people that are using stimulants, when into a system that is already very ineffective and very lacking in services and help, when everything and when the entire conversation is centered around fear and misinformation, that incites people to further vote against any kind of legislation that would enable some kind of progress to happen, which has been a pretty big issue with all this. Aside from cathinones, which have greatly increased in how much they're both available and being used, there has also been an increase in cocaine use. However, differently to a lot of other European countries, we don't have so much like crack cocaine present, more so powder cocaine, which there's also ways to speculate about why exactly it is so, from things that I've both heard and been able to find. This might be to do with the fact that in recent years, rather than the final product being imported to Europe, precursors are imported, and then the final steps are carried out in Europe, which both increases the purity of the output and would explain changes in price, or just simply availability of the substance that then reaches people. And yeah, in Lithuania, both from wasteful water analysis and also, again, from speaking to the community, there's been a more than doubling of use in the past, again, a few years. I've put together a case study that is, I believe, today been published on the Your Input site, where a lot of these things I go into more detail, since I don't know how long I've been speaking, but I don't want to branch off into things too much. But yeah, just to kind of, I guess, wrap things up. In a rapidly changing environment when it comes to stimulant use, there are a lot of issues in Lithuania which are both not being addressed, and also there's a significant lack of data to be able to make any kind of changes, which is why I strongly believe in cooperating with people in other countries and taking part in different different sorry, I'm just forgot the word, but taking part in as many different things as we can to actually be able to move certain things forward. Whether it's to improve our drug checking capabilities, since right now we primarily have only colorimetric reagent testing, and there's not, and although it is part of the agenda that is that is written by the state's plans of harm reduction, there are no actual institutions that are carrying this out on a sustained and broad the scope, and so also simply just to reduce the misinformation that is present, and to have different services available to help people, whether it is to get treatment or to again be more informed about the things that are around and consumed. Yeah, I don't know. Sorry, I got a little bit all over the place, but there's a text where I believe I'm a bit more coherent that is around. So yeah, thank you.
Thank you very much, Estera. It was a very, very good presentation, and we understood every word of it. So thank you very much. And like Estera said, her case study of Lithuania has been published today on the new Eurofood website, which is also today for the first time online. So please do have a look. You will find her case study on the front page at this point of time. So thanks a lot again, Estera. Fantastic.
Thank you.
So our next speaker is Arild Knutsen, is a colleague of mine in Norway, who will talk a little bit about stimulant use and maybe even substitution possibilities in Norway. Please, Arild.
Hello, everybody. Arild Knutsen in a drug users organization, and I'm so lucky that I know John. Therefore, I could come to you and speak to you here today. I was very early told that I should start to use some real drugs. Then I could maybe get some help. And both me and a lot of friends of mine, we were suggested to go into the opiate substitution treatment when we had severe problems with central stimulants ourselves. Norway is a country with a population of 5.6 million, and it's estimated that there is between 5 and 10,000 with severe dependence to amphetamine in our country. And it's not only that we don't get the substitution treatment like with methadone and so on, but if you use illegal drugs, you cannot you can get some psychiatric help, ADHD diagnosis, ADHD medication, or anything. So that is also something we are working on. In addition to those 5 to 10,000 with severe dependence to amphetamine, there is also an increasing number of people who use cocaine and the smokable crack. It's not yet estimated how many there are with cocaine dependence. But we have this development with heroin with lower quality and cocaine with higher quality. So we even know people that stopped using heroin after many, many years and transited over to cocaine. We hand out crack pipes, and we have a lot of information brochures, movies, and so on about harm reduction with cocaine use, and also how to make crack of cocaine without ammonia, so with bicarbonate, so that it's not toxic. We have also established a drug checking service, Oslo Drug Check, that we run together with another drug user union called Prolarnet, and we do experience changes in the market on many levels. When people with severe dependence to central stimulants get very ill, they are admitted to what we call, I don't know if I have the right phrase for it, but an emergency detox for a few days, but then they have nothing sufficient to offer them, and they disappear again. There is no evidence-based treatment that exists for those with dependence to central stimulants, only abstinence only, so-called drug treatment. There are 10 times more people coming to the emergency in Oslo that struggle with dependence to stimulants than of those who struggle with heroin or other opiates. A very large proportion of those who use heroin are staying in contact with the health services because they receive adequate medication so that they can benefit from the services. There is 8,500 in substitution treatment for opiates with methadone, buprenorphine, or even slow-release morphine. And we also have tryouts in the 2 largest cities with heroin-assisted treatment. But no one on substitution for this severe addiction. So we are in a study now that will investigate whether substitution treatment with dexamphetamine is effective and safe. The hope is that this medication can help with problems related to amphetamine or even other central stimulants. This might help people to get off the illegal drug market, and instead get in touch with and finally profit from the health services. The current project aims to investigate dexamphetamine agonist treatment among people with severe dependence to central stimulants. With severe dependence to amphetamine. It's quite funny when I talk about it. It's so much amphetamine here, and increasing number of people using cocaine, so we call it the amphetamine tryout. But when people call us from Denmark and want to talk about it, they call it the cocaine tryout. But of course, it might help people with dependence to several central stimulants. The aim is to decrease the use of illicit amphetamine in the primary endpoint with improved health-related quality of life and mental health as secondary outcomes. First, they wanted to make, the scientists wanted to make a study with 4 study arms for 24 weeks, where 25% would get only placebo, 25% would get only dexamphetamine, and 50% would get both in a double-blinded study. And it was only in the beginning, the last year, for people already in opiate substitution treatment. Luckily, they have changed the study now, so the study model. So now there is 2 study arms, double-blinded study. Half will receive placebo, half will receive dexamphetamine for 12 weeks, up to 120 milligrams daily. So they have included now some 35 patients. The goal is to include 226 patients. And we think this will revolutionize the drug treatment and the substitution treatment on overall. And also we have a tryout with substitution treatment with benzodiazepines. So this is, this is the golden standard in investigating what works and what doesn't. So if the results will be positive, it will change the drug treatment all over the world. Thank you.
Thank you very much for that presentation, Arild. Yes, I'm hoping that this study will broaden itself out as well as as it gets well known. But even though I hope the results will be positive, which I'm actually quite sure they will. So we were supposed to have one more speaker here today. They could unfortunately not make it, but I have promised to speak to speak a little bit of a message from them. My apologies again. So they say, sorry, I can't join you all today. The issue of stimulants and safe access is important to me professionally as well as personally. I've been a user of stimulants since I was quite young, undiagnosed ADHD and complex PTSD, where what I was self-medicating without knowing that's what I was doing. We often don't have positive language around substance use, but I always knew it was something helping me get through. It wasn't until later in my advocacy work that I finally had the words for my own situation, self-medicating with Adderall, or source of amphetamine, and later lisdexamfetamine has been a life-saving method for me. So thank you, John Arild, Karim, and Estera, and all the participants for joining today in this important conversation. I look forward to connecting in the future for safe supply and conversations around the pragmatic, positive, and pleasurable aspects of stimulants use. Thank you very much, Leo, for these words. I think this is actually really, really important and really at the core of our discussions here today. So, I was going to jump around to this one. Actually, I'm going to stop sharing my screen now because, yeah. So how do I stop sharing screen? Okay, that was the technical hiccup. Stop share. Simple. There we go. Right. So I want to first of all I want to thank all the presenters, and we do have quite a bit of time left. So I was wondering, Christoph, have you seen any questions come in while we were presenting?
No, there's no questions, but there's a very good, nice conversation about people that are going having stimulant problems, like Arild said, and they're going to add services to take care of the stimulant problems. And also, if you allow me to say, nowadays for this flood of stimulation, it's not possible to a program that you have it's for opioid for to take care of the opioid addiction to get punished because you use stimulation. And and also they don't give any medicine at all in or empty services with any substance near to stimulants from the doctors. They prefer to give very hard antidepressants and things like that, but not. I would like if the other people say want to make this conversation, but let's go on whatever you like. You are the leader.
Thank you. Does anyone have anything to add to Christos's? Okay. Morgan, I don't know if you were raising your hand
Yeah.
to answer this.
It was just a comment about the stimulants. I'm fairly new here. I'm on a study visit with UDA. I come from Drug Checking Los Angeles out of UCLA. So our context is pretty different, but because people are primarily using meth there. But one of the things that we did there that I thought of just now, because there is quite a few drug checking programs across Europe, we were able to use drug checking data. And in the survey, we asked people about how much they use a day. And then we compared those results with the purity results. And we were able to turn that into a milligram amount. So we were able to see how many milligrams of methamphetamine people were using. And that gives a clinical guideline for these proposals to use amphetamine substitution therapy that are totally absent from the literature. So this was actually part of my proposal with UDA, is trying to get the existing drug checking programs in Europe to reach some of this like clinically relevant data and not just like interest in the moment are my drugs safe to take, but then also these really big important questions for these novel interventions for stimulant use, such as prescription substitution, but making sure that the dosages are adequate, because we found that meth users are using on average 1,500 milligrams of amphetamine. Now that's meth, that's in California, that's a very different context, but reaching those same results would totally be possible in various countries in Europe because there is those drug checking programs.
Wow. Thank you very much for that. That's a very, very, very interesting perspective and very important perspective, I think.
I'll drop the link in the chat to that preprint paper if anybody's interested.
Please do. We are interested. Thank you. Estera.
Yeah, well, now there's two things that I kind of have things to add to, because at first was about the issues when it comes to treatment and the limitations that come with that. But this also has raised a thought, so I'll just throw in the comment about that first, and then I'll come back to this. But I think a lot of countries are severely like unequipped for dealing with things that are not basically like opioid substitution treatments. I think on one hand, there's like when it comes to like opioid substitution treatment, I feel like there's a lot of literature, and there's like a pretty clear kind of system about like this thing does this thing, and then if you take these other actions, then you have some kind of path that takes a very specific demographic out of a very specific kind of lifestyle and provides them a very specific kind of amount of support, which is not adequate in many cases, but it's still at least very like predetermined. When it comes to things that do not follow that same like mechanism, a lot of this falls apart. And I think like from my personal experience, what I can say is that years ago, when I wanted to go into some kind of treatment and just discuss what was available for me in Lithuania, I was told like upfront that we wouldn't know what to do with you, and kind of turning me away altogether, because it wasn't just one thing, in one specific context. Even that was already like enough to break the whole like predetermined path. And I think there are so many people that all have very different and like diverse just life experiences and reasons why they use, and like and then adding polysubstance abuse into that, that again there are so many variables that I feel like a lot of the treatment centers are just not equipped for at all. Also, from another like anecdotal perspective of a person that I know who was sent to treatment for stimulant and synthetic synthetic cannabinoid use, like combined, and this was I think around 2016. So again, not too long ago. Like yes, some time has passed, but not too long ago. They literally were about to put him on methadone, where it's like this has nothing to do with it, and he had to fight to not be put on methadone, and they were confused, like, you know, you have issues with drugs, we are throwing our single one size fits all solution, what's the problem? And it's like completely different things. um and I think that level of like just not having some kind of strategy exists in a lot of countries. And like I think in more Western Europe there's still a bit more history of some kind of treatment and some kind of at least beginnings of projects that are happening, which can which are going somewhere. But then I think in Eastern Europe or in countries that have where until recently you've not even been able to talk about any kind of substance use and be considered as a human being. I think a lot of these things are like so far back, and there's just so much that has to be done where it's almost frightening to think that that these things are currently still happening. And just a quick thing that I wanted to add to Morgan's really, really interesting idea of like calculating these things. I think one slight issue when it comes to the context here is that even in countries where drug checking is available, a lot of the time it's there isn't, well, not many places have the qualitative analysis of purity available, and I think that's also an issue. With Young Wave, we've been wanting to improve our drug checking methods for a long time, and it has been difficult because again, without funding of any sort, which kind of just relies on projects and individual donations, it is a big step to be able to get enough just to get the equipment. And then with the equipment, there is also just like the implementation of it to be able to actually be able to get the samples and be able to gather enough data to start to make these conclusions. Though it would be so amazing to do something like that, to be able to make correct estimations of purity and about like individual needs for each person, that would be such a massive improvement on things. But it is difficult when in many places the drug checking that's available is very limited, on one hand because there are no like full-on labs that would be allowed to do that because of the very high levels of criminalization, and then on the other hand, to be able to implement those things. But yeah, like I wish we could, like I would love to work towards getting to something like that. I think that would be really amazing. Anyway, thank you. Sorry.
No, no, no. Thank you very much. I think that also this is kind of a place where your input also falls a little bit in, where we can mobilize and raise awareness that this is needed, and these we have solutions, but hey, we need also the funding for these solutions. So thank you very much, sister. This is very, very valid points. Arild.
Yeah, thank you. And thank you, Estera. I also had to fight to not be put into substitution treatment program with opiates like methadone. I wanted to comment on medication for ADHD when you are in substitution treatment for opiates. Maybe you should, Christos, ask your experts in the country to look to actually Sweden. In the substitution treatment program, OAT in Norway, there is, I think there's 3% of those receiving ADHD medication. And in Sweden, they are progressive on that issue. There is 10 times more, actually 30%. And when Sweden can do that, then the Swedish experts can tell you that that is the right thing to do. And I wanted also to comment on the 1500 milligrams of methamphetamine. Here we use, we call it amphetamine sulfate. And of course, we also use high dosages, but it's not like with opiates that you need the same level of dosage. I have experienced that myself and a lot of friends of mine. I mean, injecting amphetamines many times every day, and then we usually took maybe 20 milligrams dexamphetamine 3-4 times a day, and it really helped us. So, and that is not addictive, but the use of very potent and very much very high doses, of course, is very addictive. So this is, yeah, it's much safer kind of substitution treatment than with opiates. But, and I want to close with saying that I think there's a lot of people that does not receive, the diagnosis for ADHD, the medication, and really struggles with central stimulants that we never, the health services never reach. So I don't think we should have no liberal prescription or sales or anything, but it should really be legal. 5 milligrams tablets in with the dexamphetamine. A licensed sales for people already using or something like that. I mean, you're not sick, you're not a patient, you don't need treatment, you don't need therapy because you need to use that kind of medication. So we should bring in another level of availability.
Thank you very much for those words, Arild. That was, also some thoughts on that side. Definitely when it comes to do ADHD, I'm happy to hear that Sweden is doing something right. Rui, please.
Yes, thank you, and thank you for this doing this webinar. It's super important because it seems that services only found out now that there's lots of people using crack and at the same time in treatment. And for users, it's a reality we known for a decade or something. And services only 2 years ago found out that this is such a big problem. My question is about the differences of treatments and solutions that in different places of Europe they found out. And in my case, I managed with the public services to have a prescription of methylphenidate. And I have no specific dosage. So sometimes I use more, sometimes I use less. And when I need more, I just send a message and I receive the prescription on the mobile phone. It's very quickly. And it's since 2018. But I know that I'm not use normative solution. I don't know anybody else that is having this prescription. So I find that there should be golden standards. That there should be the best solutions, and I think that your input should be on a. It is on a good position, I guess, to propose on developing these standard solutions from the point of view of people that use substances. Yes. just this. Thank you.
Also, I'm sorry, Rui also make one question about the driver's license. You want to make this question in the chat?
Yeah, Karim, because I found out, I asked Karim where there's no studies on each substance and quantity and the impact it has. For instance, in alcohol, we know that above certain amount of alcohol per million of blood, there's an impact, a certain impact. But for the other substances, there are no studies. And if they are doing, chasing the license, with no evidence base, I think it's again a punitive only solution that doesn't look for studies. It's a rather more emotional and punitive than a rational solution, I guess.
I think you're very right about that, actually, Rui. And this is quite interesting, because also being on lisdexamfetamine, for example, they write this out these days in Norway as well, lisdexamfetamine and dexamphetamine, and every medicine that has some kind of bad influence on your driving has a red little triangle on it. Now, because there were so many ADHDers coming up, they decided to actually remove that little red triangle. But that does not mean that if you get stopped, and they do the spit test, that you will still then, because you get positive, you have to come and do the blood tests. So it's a double-edged sword in a way. It's a solution, but it's not the solution yet. And yes, I think raising levels of like how much and so would be a bit more precise in this kind of stuff. And also, I think about prescriptions to people, and I'm very happy to hear that you have the possibility to actually adjust your thing. I think for very many people it is kind of like dominated by fear to ask to increase the dose. If I ask, what will they think? They'll think I'm trying to get more drugs. So it's kind of like this whole
but it's
narrative.
A battle. It's a battle.
Yeah, it's a battle, and this whole narrative is so it's so wide and so far-reaching. So yes, Karim.
And there's a
Yeah,
distrust. They from the first moment, the services rarely trust users or patients that they know something about their own body and their own minds, and so also it was important to have services to trust more on the knowledge the patients have.
the expertise of people who use drugs, right?
Yeah.
Karim.
About driving license, in France, if you drink Friday and you have a check control Monday, it's okay. If you smoke cannabis Friday and you smoke Monday, you lose your driver license. Okay, it's not the same. You're dangerous where you are drunk, but not if you were drunk 3 days before. It's different. And it's the same for cannabis, it's the same for cocaine, it's the same for heroin. So it's just punitive policies. It's nothing, nothing else. Just one or two reflection about substitution of from stimulant. I love substitution. I think it's really useful. I think study about substitution from stimulant is really useful, but it's not for everybody. We have to quit this pathological concept of many people. Some people need substitution, but drug use is not pathological behavior. It's not pathological context always. Okay, and if our response is just medical response, is just it's dangerous. For me, drug use is a freedom. Okay, and some people need help, and some people need medical help, but many people don't. For many people, it's not a problem. It's just it's just freedom issue. And another thing, substitution from stimulants, it's okay when you need stimulant, but how can I say? When you smoke or when you inject, you have an elevator effect. How do you say? Really quickly, you have you pass a step and another step. How do you know? Sorry, in English, I can explain. And this
You get
elevator
high.
is researched by crack user, is researched by injector, drug injector, etc., etc. Or this substitution we don't have, we can't have this effect. I think it's thinking about we need opioid with opioids we need to have opioid in blood. With cocaine, with methamphetamine, with etc. We don't need to have. We need the effect different.
Okay, yeah. Okay, you're saying we don't need it to be stable. Some of us need it to basically just get high. I believe
Yeah,
that's what you're saying, and I'm thinking that's perfectly valid. That's just 100% valid.
that's why.
You know,
Can I say just that's why I don't take the methylphenidate of long acting, because there's the long
yeah.
acting methylphenidate, there's the immediate, and I take the immediate methylphenidate. And if you take 60 milligrams or something, and snort it or something, you get high. It's yeah.
Because I kind of think we also get into the area now where the discussion actually gets even more interesting, and it is where we talk about whether, hey, on the one side, yes, if we have a challenge, people who have a challenge should have help, but people who don't feel they have a challenge but just want that, we I think this, in my personal opinion, I think we should at least not punish those people. And if you are clever as a society, we will include them and make life not more difficult, or to make life difficult to start with, actually. So I think those are very, very valuable insights, and I think they definitely belong in this discussion. It makes it, and this is what was for me making this stimulant resource. When I started it went on so many different levels and so many different ways that yeah, it would be a work that I could start, but I could never ever complete in my lifetime at least. So thank you very much for those things. Anybody else have anything to ask or any comments? No.
May I?
Yeah, of
Sure.
course, Christos.
I think there's a very big problem from the services over line in urine testing. Like the previous speaker said about people may want to use drugs. This is not um, in my services here in Greece. They say that the urine test is the basic therapeutic tool, and this is really so wrong. This is poisonous. You don't have any relation with your key worker. You don't have
Yeah.
anything. And people that are working the services, they burn out because they can't help anybody. It's in all the ways it's poisonous and poison everybody. They have to stop this, and we have to put EUDA to say in the recommendation to stop, very clearly, because they don't say it very clearly, to stop this being the basic therapeutic tool. This is very important, and we have to understand that people might want, or also, 18 people, they don't want to use drugs every day. They might use once a week. What is what is so big trouble that they use once a week or once a month? That's what I wanted to say, because we have a lot of trouble with this here in Greece. Thank you.
Thank you very much, Christos. These are definitely important things, and I think that these are things that Europe also should have a leading voice and a loud voice in fronting, because these things are, things that we can talk about, things we can put forward, things that we can address, So these are very concrete things. So thank you very much for that perspective, Christos. Very, very good. So if there are no more questions or comments, then I would like to thank you all very much for participating. And please also, if there's anything about stimulants or anything else about drug, please take contact with us as Eurompod. We're always like to hear new voices. We always like to hear all kinds of perspectives. So thank you very much for joining today, and have a nice evening.
Thank you. Thank you.
Thank you very
Bye-bye.
much.
Nice to see you all.
Thank you.
Likewise.
Bye-bye.
Stop recording.